This video is brought to you as part of the Paired Health Mobile Medical Care Educational Series. In this video, Cathy Holland will introduce you to her role as a clinical care coordinator within the Paired Health Transitional Care Program and how the role of care coordinator drives consistency and efficiency by streamlining the management of the patient referral pipeline. Here you can see the four components of the Paired Health platform that enable a hospital or health system to reach patients in any setting outside of their four walls. As shown here, the clinical care coordinator would be responsible for steps 2 and 3. As you will hear from Cathy, referrals for follow-up care come to her for acceptance to the program based on a set of predetermined criteria. Next, the patient is risk stratified and enrolled into the most appropriate care plan, then is scheduled for follow-up with a field provider based on both clinical and geographic fit. Ideally, the care coordinator would be staffed by an RN level due to the element of clinical knowledge required in the patient acceptance and risk stratification steps. As the specifics of each step here, program acceptance, risk stratification, and scheduling are all covered in dedicated video modules. This video will serve as an introduction to the care coordinator role and will also give you an idea of the workload and resources required to staff this position. While the process has proven to be more efficient when streamlined into a single person, the different responsibilities may be allocated based on your particular program's available resources and needs. At a minimum, both the stratification and scheduling can be done by the individual or providers delivering care to the patients in the field if it were necessary. However, as you will hear from Cathy, by allocating a resource or fractional resource to the management of each step, the provider teams in the field are able to be exponentially more efficient, freeing up their time to focus on the care being delivered to the patient. First, we'll get a quick overview from Cathy on the care coordinator's involvement in the process from when a referral comes in through to when the patient is initially scheduled with the mobile care team in the field.
We get referrals two ways, from inpatients or from patients who have been in the ER who were not admitted, but the doctors felt they needed to follow up within 48 to 72 hours. And so the inpatients are from case managers, and the ED quick follow-ups, what we call them ED quick follow-ups, are we run a report every morning and generate those requests. And so what I do is I get the email, I look into Sorian, which is the current charting system that the hospital uses, and I just read through the charts. If it's an inpatient, I read their H&P, any consult notes, case management notes, nursing notes, and I make sure the patient's appropriate. So I look up their address to make sure that they're in Wake County, and then I make sure that they meet our criteria for meeting. So obviously the inpatients take a little more time to review as there's more chart to review. The ED quick follow-ups, I simply review the ER visit and usually just skim through the chart and then read the doctor's progress notes and any dispositions that they may do. It doesn't take long to read through, an H&P. I mean, it's maybe 30 seconds to a minute depending on how sick the patient is. And I just look for, a lot of it, I look for clues for accepting the patient. Most patients we accept. If I feel the situation's unsafe, I won't accept the patient. So I do read some of the social history, the case management notes about some of the social aspects of the patient. And if I feel if it's not safe for our care team to go into the home, then we will reject those proposals. But it takes about 30 seconds to a minute to read a chart. It's not that long. Really just looking for the key factors is what is their medical condition, what medicines do they take, and then that gives me an idea of how soon we need to see them and when I can schedule them for a follow-up. And also it gives me an idea as to when I think they're going to be discharged. And then they are put in from proposed to accepted. And then once they are, once I get in touch with the patient, I try to contact the patient, and then they're activated and put into service for one of our providers to follow them up.
So once the patient has been accepted to the program, how do you typically introduce them to the home visit program and schedule them for a visit? And is that typically done over the phone, or do you visit the patient in the hospital to schedule the visit face-to-face?
A lot of times, unfortunately, I'll get a referral and the patient will go home. So if I've got a couple patients at the hospital or even one, I'll just go to the hospital, and I usually check in with case management. where the case manager on the floor who did the referral, and then I'll just go see the patient or patients, spend some time in the room talking about what is paired health, what do we do, and give them a card with my name and number and their appointment time on it. We set that up, and then I speak with the primary nurse and the case manager and just let them know that we have an appointment scheduled, and if they could please put it on the discharge papers. And just finding that it's easier to explain it face to face sometimes than on the phone, but also knowing that when on day of discharge and even in the hospital, patients are overloaded with information. So, just that extra contact, I think, helps instead of on the phone. When they see face to face, it helps a little bit processing what we're actually doing.
Can you give us an idea of how much time is required to handle each patient referral that comes in, and what would you say the typical volume is that you're able to manage on a daily basis?
Yesterday, I got, I think, 12 referrals yesterday, which is a lot. And I just, it takes time, but what I do is I kind of developed my system. I have a notebook, that I keep notes when I risk stratify patients, or, write down their information. And I just kind of go and I do that part. I do their MR, and then I just go into the EMR and I look everybody up and I make notes. So then I go back to the paired health software, and I just, can accept, schedule, and kind of just go system by system. Most days, Mondays are usually busy from the weekend, and so that was kind of an exceptional day with that many. I think I've had as many as about 15 in a day. It's usually not that many though, but really per referral, it maybe takes 5 minutes per referral. It does not take a long time to do the referrals. The longest part is calling the patient. Because if I have to leave a message and then I call again the next day and leave another message, and then, just trying to get in touch with the patient usually is what takes the longest. The scheduling part is the longest part of it, but the actual getting the referral, reading the chart, and accepting it is maybe 5 minutes.
Would you say that there are benefits in allocating these responsibilities to a care coordinator to manage versus relying on the mobile field providers to review each referral, do the risk assessment, and schedule patients on their own?
Oh yes, they don't have time to, do this, because they have to, they do read the charts, but they're reading the chart as the next step. I'm reading the chart as, what is your course right now? What's going on with you right now? And so when do we need to see you? And they're reading the chart as, what do they do? What do I need to do for the next 30 days to keep you from going back to the hospital? So they're reading it from we're really doing two different perspectives in that's part. They're looking forward and I'm looking current. And then they are, they're preparing their new charts, but they've also got multiple other patients that they're still in contact with and still working on. So they just really don't have time to then call and try to schedule a patient. Now they do schedule their own follow-ups, which is nice, and I'll work around that. We're working on, they need to tell their follow-ups. They also give a window, and then that way I can move follow-ups based on a new patient coming in and where they live based on the follow-ups, and moving people around a little bit. So they do schedule the follow-ups while they're with the patient, which makes sense to do the next visit. But the initial appointment would be not time beneficial or the best use of time for the mid-level or the doctors to schedule.
As your program's volume grows and resources become available, staffing a dedicated or part-time clinical care coordinator to manage the patient acceptance, stratification, and scheduling process will certainly drive efficiency and effectiveness. However, if that's not in line with your current program goals or budget, there are other options. For example, separating the clinical review and stratification element from the scheduling function, or even pushing these responsibilities to your field provider teams to manage. As a third option, Paired Health does offer the care coordination role as an outsourced support service. If interested, please reach out to us to learn more about this option. Also, please check out the dedicated video modules on patient risk stratification and patient provider scheduling to learn more about the specific functions of this role. Thank you for watching this segment of the Paired Health Mobile Medical Care series. Remember to check out the rest of our series and much more at www.pairedhealth.com.